Welcome everybody to the webinar on the unspoken and hypertension management, why America can't control its blood pressure. My name is Yair Saperstein. I'm the CEO and co-founder of AvoMD, and it's a pleasure to have with me Dr. Brent Egan, Dr. Martha Gulati, Dr. Eduardo Sanchez, Dr. John Whyte, and Dr. George Bakris. We'll go around the room for everybody to be able to introduce themselves, and then we'll get started diving into the topic. Dr. Egan?
Yeah, thank you. I serve as Vice President for Cardiovascular Health at the AMA and have a long-standing interest in translating clinical science and what's known in clinical practice into the field, into primary care. So I've been doing that for the last 25 plus years. Very happy to be part of this group.
Pleasure to have you here. Dr. Gulati?
Hi there. I'm happy to be part of this as well. My name is Dr. Martha Gulati, and I'm the president of the American Society for Preventive Cardiology and a preventive cardiologist at Cedars-Sinai.
Thank you. Dr. Sanchez?
Howdy, everybody. My name is Eduardo Sanchez. I serve as the Chief Medical Officer for Prevention at the American Heart Association. Started my career as a family physician in a federally qualified health center, and now I'm overseeing a big project to try to improve blood pressure control in 350 federally qualified health centers. Pleased to be a part of this and to be with all of y'all.
Great. Dr. Whyte?
Welcome, everyone. I'm John Whyte. I'm the Chief Medical Officer at WebMD, and I'm a practicing internist here in the DC, Virginia area.
Pleasure to have you. And Dr. Bakris, last but not least?
George Bakris. I'm a nephrologist and a clinical trialist at the University of Chicago Medicine. I direct the American Heart Association Comprehensive Hypertension Center there, and have been doing clinical trials in hypertension outcomes as well as kidney disease outcomes for the last 30 years. Happy to be part of this, representing Up to Date.
And as we can see, we really do have the experts in the room here who are joining me, and it's an honor to have you all here. I think we'll get started just broadly, and as I ask this question to frame it, I'll address each person, but feel free to jump in with your own opinions, especially if you agree or disagree, so that our audience can really understand the breadth of opinions here, with the hope of really coming to some sort of agreement as to how can we all practice better. How can we help America control its blood pressure? And how can we deal with hypertension management more effectively? So we'll start, Dr. Egan, with the broad question for you. Why is blood pressure still uncontrolled in the United States?
A huge question, but let me just focus on two factors for the initial discussion here. One, we have adverse lifestyle patterns in an aging population, which drives a very high burden of chronic disease, and particularly cardiometabolic disease, which raises blood pressure and makes it more resistant to medications. It takes more medications to control somebody with cardiometabolic disease than without cardiometabolic disease. The other major issue, and there are many, is controlled and uncontrolled hypertension are not fixed clinical traits. We often talk about them as they are, but many patients are intermittently controlled, and particularly patients at 150 to 160 or 140 to 150 rather are controlled 40 to 50% of visits. Patients at 130 to 140 are controlled at 60 to 70% of visits. So while we're critical of the clinician, what they're seeing is a patient coming in about every other visit roughly in control, when in fact the control is really suboptimal. And I think those are two major issues among many, but just wanted to start there.
Great. And to follow up on that, if at the clinician visit, the doc is seeing that the patient is controlled, right? And then we're seeing that the patient is actually not controlled. Where is that data coming from that we understand that the patient is not controlled? And how does that data get incorporated?
Okay. It can occur in a couple of ways. One, it's visit to visit. So the last visit they were controlled, this visit they're not. If I wait another visit, they may be back in control. And that's particularly for patients that are in that 130 to 150 range. And the message I'm going to say here is, if we want to get the patient consistently controlled, and if clinicians, we want to achieve high rates of control to less than 140 over less than 90, we need to get the mean systolic blood pressure to less than 130. Most clinicians are unaware of that. A lot of folks that write guidelines are unaware of that, but that is the reality. So consistent control for most patients requires a mean systolic blood pressure less than 130 to get to less than 140. Now, the variable information may come from directly measured blood pressure, automated office blood pressure device with multiple measures, or the patient may be doing self-monitoring and either transmitting that to the clinic or bringing in a sheet with values written down. So there's various sources of the information. Not a lot of ambulatory monitoring is done except in specialty clinics, but self-monitored blood pressure, more usual single office measurements, and then the automated office blood pressure, which is becoming more common, where typically a series of 3 readings is obtained at 1-minute intervals and the average obtained. We're seeing more of that data getting into electronic health records.
As a follow-up there, Dr. Gulati, what are your thoughts on who is the data most important for? Is it most important for the clinician to understand? Is it most important that it's recorded in the electronic health record? Is it most important that the patient understands it? And how should we think about this?
Well, I think we talk about patient-centered care, and so it should always be focused on the patient, and the patient is a partner in their care. So I think they're the central component. They, of course, should be understanding, and we should not underestimate engaging our patients and helping them be an engaged patient to take control of their blood pressure. I think a lot of it is us and underestimating our patients and their desire to be involved in that. I think, though, that for your first question, though, about why we don't do such a good job in controlling blood pressure, in addition to what has already been said, I think there's a lot of clinical inertia in terms of even caring. We know there's errors in how we measure blood pressure, but office settings, our clinical settings, we don't take the time in most clinical practices to really focus on doing it right. Relying on blood pressure and the control of blood pressure is such an easy intervention. And yet, I think the majority of clinicians do it wrong. Additionally, even the value of home blood pressure measurements, which I think are excellent and should be our standard of care, we have not embraced them in our US guidelines. And so that's part of it. And then I speak as a cardiologist, so I would just say that we are much more focused on sick care, not health care. If one of the things we did do was intervene on blood pressure earlier, we would have a lot less cardiovascular disease. We need to be making this, like webinars like this, but more efforts to really using these as quality metrics for how well we're caring for our patients.
And to turn to Dr. Sanchez, and by the way, guys, if you have thoughts on any of these, just because I'm addressing it to one, feel free to jump in, make it even more interactive for our eager audience. So, Dr. Sanchez, I address to you, but anybody, feel free to chime in after Dr. Sanchez. As we're discussing the importance of measuring blood pressure and the blood pressure control, I have heard from some others that we as a group of clinicians are more aggressive in controlling blood sugars than we are in controlling blood pressure. Do you agree with that sentiment? And if so, why? And how should we deal with it?
Well, I think I do agree with that sentiment. I'm not sure that I could tell you exactly why. I think that in some ways, even the variation of age amongst us in our training, blood glucose control was just hammered as critical, and maybe not so much blood pressure control. However, we are all sentient beings who can learn even as we age. And it seems to me that the one thing we do have now that maybe we didn't have 20 years ago is a clearer line of sight between blood pressure control and the importance of getting to blood pressure control sooner rather than later. Not having the attitude that I will admit I was that doc 30 years ago who might see Mrs. Jones and her blood pressure was 145/95 and say, well, I'll see you back in 3 months and we'll see what happens. Well, what happens? Blood pressure either stays at 145 or 95 or gets worse. But I didn't necessarily appreciate as much as I appreciate now the consequence of not getting things under control quickly. So I think that, and you asked about challenge. I want to address that for a minute. I think one of our challenges is the inability for us to successfully translate the what the science is telling us, into the how to get it done. I think that as I have said with others, there is an opportunity to be more systematic, more standardized, and I'm going to use the P word, more protocolized about how we do blood pressure control, so that 95% of the time, maybe it's a little bit less than that, but just go with me here. Let's see the 80-20 rule. At least 80% of the time, following that systematic, standardized, protocolized way of getting business done is going to get you very much closer to goal than where we are now. And one other thing is that you talked about who should have the values. Clinician, I think you said physician, the health record, the patient. I'd say yes, yes, and yes. And actually, the entire team needs to have that value. You heard me say when we were talking the other day, primary care is a set of functions. It's not one person. It's not one discipline. It's a multidisciplinary, multi-pronged approach that includes patient as the center and maybe the lead of that team. And everyone should have access to that critical information that says we're where we want to get, or we got some room to go, and let's do the things that we need to do to get there.
Let me follow up on a couple of these things, because first of all, let me say I agree with everything that's been said, but I want to take it to the next level. So I'm frequently asked to lecture around the world, and I've been asked to summarize guidelines, and I've been asked to do all this stuff to simplify things. And at the end of the day, what you've heard from Martha, and what you've heard from Brent, and what you heard from Professor Sanchez is the bottom line. The bottom line is physicians aren't stupid. They know what they need to do. The problem is the system does not allow them the time to do it. The system does not encourage them to do it. And on top of that, wasn't bad enough, you have the payers who won't allow them to give evidence-based medicine because it's too expensive for the patient. So at the end of the day, whether physicians realize it or not, and I'm going to just say it, we're being held hostage by the business people. And, as a senior physician, I'll take some responsibility for that, because we kind of gave them, we didn't want to be bothered in the 1970s with this stuff. And here we are, we're now a prisoner. So this is what needs to change. Educating people, great. Making it easier, great. But I will tell you, in my own institution, when the guidelines came out, and I actually had a session with the nurses on how to measure blood pressure. And at the end of the day, the nurses were excited, but the physician said, and the administrator said, no one's paying us for that. So just do it the way you did it. So the only people getting blood pressure measured correctly are the people that see me. And people are shocked that all kinds of different numbers are coming out, and they don't understand why. It is education, but I think somebody's got to, bite the bullet and say, listen, this is the problem.
Yeah, I would build on George and say the clinicians really are not lazy and they're not stupid. I want to endorse that. They do see, again, when we look at the health systems that we're working with on hypertension control, the average patient comes in with 9 chronic conditions, typically for a 15-minute visit. That's challenging in itself. It's been estimated that it would take clinicians 26 hours a day to implement the evidence-based guidelines for the patients they see each day. And we don't surround them with the systems and support that allow them to do that within the usual workday. It's a terrible problem. So as I said, you've got a patient coming with 9 chronic conditions. They're controlled on half the visits, which is suboptimal. You've got all these other issues in addition to the acute complaints the patient's talking about. And we do not have systems to put the data in front of patients. I wanted to go back to why diabetes, I think, is better managed. One, we don't have a hemoglobin A1C, and even a 24-hour blood pressure doesn't get us there. The average patient has a standard deviation from visit to visit of about 10 millimeters of mercury, and that standard deviation across patients is a bit larger than that. And so we've got a lot of variability, and the noise in there with intermittent control. I think most clinicians don't know the percent of visits the patients control, whether it's self-monitor or otherwise. I don't think that most electronic medical records tell them what the mean pressure is that they've achieved. Now that data gets us closer to A1C, but again, we don't have the systems and support that make it feasible within the time available to do a good job. I think having an A1C is great. I want to also point a bit at us. I think the experts in diabetes have done a better job of raising the platform and getting a bigger bullhorn than we have around hypertension control. So I want to give them credit for that. Also, the marketers of anti-diabetic medications have a much larger platform and a much more to say than marketers of antihypertensives. And, there's a lot of direct-to-consumer advertising on diabetic medications. We don't have any of that with hypertension. There's more detailing to the clinicians on those medications. We don't have that happening with hypertension. So I think, it's partly incumbent upon us as experts in the field to make more noise and let people, as George and others have said here, how important it is to control that blood pressure. I'm going to be quiet, but I think those are some issues.
No, but I want to quickly build the ADA, and I've been part of them for 20 years. The ADA very much has taken some good advertising tips. So, and just watch Anthony Anderson now with a commercial that they've got out now, threatening you with blindness, loss of limbs, and all kinds of things. All true. What are you going to do with hypertension? You're going to threaten them with the same kind of thing? I don't think so. So the patient walks away thinking, well, yeah, but I'm not going blind and I'm not losing my leg. So they're going to, and back to my point, the ADA has lobbied big time, industrial strength lobbying for more money to support the diabetologists to control sugar. Nobody's done that for hypertension per se. They've done it for heart disease, clearly, but not for hypertension.
Well, I think also the attitude that we teach, we know we're not checking blood pressure correctly in our clinics for the reasons that you already outlined, George. And that, that we know they're not well done, so we ignore them. So we don't act on them. Our patients also learn lessons from that. If they have a reading that is, 160/90 and nobody acts on it, even if they're doing home reads, they're like, well, nobody did anything in the clinic visit. I had this high read. So the importance of it gets diminished by our actions too. But I do still think that the argument in our clinics to not add the extra 5 minutes of how, of measuring blood pressure appropriately is really misguided if we really care about the health of our nation.
I just want to jump in as someone who still sees patients. So let's keep in mind, there's a lot of priorities during that 15-minute visit, right? So if we want to add 5 minutes for blood pressure, other people can be saying, we're not doing the ACC, AHA risk calculator on enough people. I got to talk to them about colorectal screening. I got to talk to them about mammography. I can't do it all in one visit. And I do agree with Dr. Egan that the hemoglobin A1C fundamentally changes how we think about blood sugar. But also we need to think about our quality metrics and how we're evaluated as physicians in the clinic. And most clinics, most health plans are going to grade physicians about how many patients that have diabetes have a certain A1C and whether or not they're on a statin. I'm going to get a gazillion reminders on that. So there's many ways that, blood sugar is managed very differently. I don't think that blood pressure is measured wrong per se in the clinic. I agree with Martha's point that we kind of send the message that it's not so bad. If your blood sugar is high, your A1C, I'm labeling you pre-diabetes. I'm having a whole plan. I'm making you go see optometry, ophthalmology, the foot doctor. And you're right, with blood pressure, I'm like, let's check that next visit, right? And then to Dr. Sanchez's point, I'd say a lot of them don't come back in 3 months or 6 months. They come back a year, and then it's still a little high. Or guess what? I'm seeing someone else in the practice's patients, and I'm thinking, I don't know if I should increase their medication or add one. And then 5 years have gone by. I think a lot of patients know that high blood pressure causes strokes, right? They know that, they've heard that somewhere. More so for that than heart attacks. But then we don't reinforce, we don't follow up. The clinic that I'm at, we focus very much, you come back for a blood pressure check. If you're not going to do it at home, if you're not going to, go to a pharmacy or whatever, I know we'll talk about, this is the role of tech. How do we use the role of tech? Because it doesn't really matter, and this is where I would nuance Martha's point, it doesn't really matter what their blood pressure is in the office. It measures what it is at home, measures what it is in the evening, what it is in the morning. And that's where we're not empowering clinicians with the data that they need to make the right decisions and to have those conversations with patients. And then how do I prioritize everything in that visit? That right now the clinics are packed. There's a lot of issues that people have.
We addressed the issue of the blood pressure measurement in the following way, and that is the clinics that we work with, most of them obtain the automated blood pressure devices. They do a standardized protocol. They get the 3 readings. They've learned to leave the room and do other things so that they don't lose as much efficiency. We thought it would change the intensification rate, but it really hasn't changed the intensification rate. So even though they were trained that this is a better blood pressure, more reflective, not perfectly, but better reflective of self-monitored blood pressure than the usual office blood pressure, so far it has not been changing the treatment intensification.
Right. So I'm going to jump in and ask, if I can, who's had a patient that's had low blood pressure when their blood pressure dropped, right? And Martha, how do they feel? They're not willing to adjust their blood pressure again, right? So would you agree with that, Martha, that sometimes there's this fear that once their blood pressure gets too low and they get dizzy, they get lightheaded, they get a presyncopal event, they're like,
I mean, definitely there is those patients, but there's also so many other patients that you can make better. So
but it's managing it. We don't have that conversation with patients. And then you're right, that doesn't happen that often, but once it happens, it kind of changes everyone's perspective.
So let me opine on that, because as a referral center for the most difficult to manage, I see this a lot. I try to prophylax against that by making sure that, because I use truckloads, as you can imagine, of ARBs and ACE inhibitors, I tell the patients, if you're not drinking at least 1.5 liters of water a day, you're going to have a syncopal episode, because these drugs are super powerful if you're dehydrated. They don't know that. And if they do have a drop in pressure, they alert me immediately, and I immediately make changes. Guess what? I can do that because I have the time. If you're in primary care, the last thing you want, I'll never forget this. Why were DPP-4 so popular, even though they do a crappy job of controlling diabetes? No phone calls. Physicians love them because of no phone calls. Let's be honest. So you're going to get phone calls from this, and then the patient's going to be reluctant, which requires an explanation, more time. So this is the problem. That's that 4-letter word time that the physician doesn't have and needs to be able to get them back on track.
Are you pro or con on drug combos? Because here we want to increase dosage, like diuretic and ARB or ACE inhibitor. Then when you want to change it, it becomes a challenge.
But listen, you're talking to the guy that in 1996 wrote guidelines that combo should be first line. And why do you think the European guidelines went first line? For adherence issues. But I don't use diuretics as part of that. I always use them as a backup, because I know these people are going to be eating truckloads of salt. You'll get hyponatremia, you get all this other stuff. So the issue really is.
But your combo is not a combo pill, or is it?
Oh yeah, no. It is a combo pill. It's a single pill combination. And
which one is it?
What is it? What do I use?
Which one do you use?
Well, I'll tell you, I use a CCB with an ARB. Because I don't want cough. I don't want angioedema. I see a lot of patients that are black, and I just want to avoid that. And not that you totally avoid it, but you definitely reduce it. But I think the point, I want to get back. I've seen a number of patients, not a huge number, thank God, but a number of patients that have come to me with pressures of 180 to 200, referred on meds, inappropriate meds, but on meds. And we get them controlled down to 150, 145, and they think they're cured. And I said, no, we still have to go. And they go, well, wait a minute. I never saw this low pressure. They're scared to go lower because they don't know what's going to happen. And their doctor said 160 is fine. So I don't know what the problem is. So this is the messages we send to patients. They're going to take them.
So it sounds like there's a bunch of issues here that I'm hearing so far. One of them is the payers, and I'll ask a little bit more about that because we have a question from the audience. Second is the message that we as clinicians are sending to our patients that it's not as important as other things like diabetes, whether that's coming from advertisements, from the clinicians ourselves, or from other channels. And then just the difficulty in dealing with it. It's if the pressure goes low, the patient doesn't want it anymore. It might be akin to hypoglycemia if we compare to diabetes, but now we have drugs that can help avoid hypoglycemia, and so we've dealt with that. We don't quite have that within hypertension unless we tell the patient, drink a lot of water, which can sometimes work and sometimes not, depending on what other conditions they have and the difficulty is in dealing with that. So to follow up on a couple of these questions from our audience, one, Dr. Bakris, could you elaborate on your statement that payers do not allow physicians to practice evidence-based medicine? Can you give an example in particular of how this applies and what we should do to help lobby the payers to solve this?
Well, the ADA guidelines, the kidney guidelines mandate practically the use of SGLT2s. Go ahead and write a prescription for SGLT2. If you don't have a good prescription policy, good luck getting it filled. The patient doesn't have the money, you're out. The more recent findings for people with kidney disease and with diabetes for non-steroidal mineralocorticoid receptor antagonists, good luck. They're not funded. So the insurance plans will only allow so much. And then the pharmacy benefits managers are the ones that are really the gatekeepers to prevent the evidence-based medicine. It's not so much the insurance plans, but the insurance plans are a function of what the person can afford. So there's discrimination big time, because if you can't afford good policy, you're not going to get top quality care. Not that the physician doesn't know to give it to you, but if he tries, the patient is not able to put it forth. So that's the point. The other point is not carefully measuring blood pressure in the office, getting back to the hypotension. Guess what? You're going to be treating a lot of white coat hypertension. Guess what? They're going to go home and they're all going to be hypotensive within the hour because you're inappropriately treating. And then they're going to think the physician doesn't know what he's doing. So that's why you need to measure it properly.
And on that topic, Dr. Sanchez, also bringing in some of the audience questions and to touch on Dr. Whyte's topic mention, can you discuss a little bit more about the role of tech in hypertension diagnosis and management? Talk about medical grade versus not medical grade, at-home BP monitoring versus in-office measurement, and a topic that's particularly close to my heart as we think about protocolizing and how, right, you had mentioned about really the need for more protocolizing. How do we do it in a way that everyone can agree, can get the payers on board too, and allow for tech to bring evidence-based medicine into practice? So there's a lot there, but incorporating some of the questions that we're getting from the audience.
Yeah, there was a lot there. So I would say, with regards to equipment, we are aligned with the American Medical Association and others around using validated devices. And validate.org is the place to go. And Brent, if I got the website wrong, let me just blurt it out. But validated devices first. So the right device, making sure that it's regularly calibrated as directed is another important thing. You know, those of us who don't get oil changes except every 25 years have cars that don't run as well as those of us who get oil changes more frequently. And then the right technique is really important. That's not only important in the clinical care setting, that's also important at home. So one use of low tech, but delivered in a tech way, is helping patients learn how they can do SMBP well. And I couldn't agree more with Martha that one of the things that we sometimes do a little too much of is not give our patients the power to control what they can control. They can do this. We just need to provide them the right guidance and the right opportunities to succeed. On the tech side, when we can, and I'm saying when we can because many patients may not have internet access in their homes. So high tech, when it can be used, Bluetooth enabled devices can make it possible for, with the right protocols and the right APIs and the right translation of raw data into an average value, and can give clinicians the information that they need and the patient that the information they need, that number that says this represents, back to the point you were making, Brent, it's not quite mean systolic blood pressure, but it gets darn closer, right? If you've got numbers that stretch out over 7 days measured by protocol. So tech can be used to, so I like to talk about titrating high touch and high tech. So the high touch is giving people that guidance and support. There are community health workers that might be used in a clinical care setting. There are care coordinators that can be used to do the support for what needs to happen at home and happen well. There's ways to provide folks, again, with that written material or web-based material that they can use to reinforce the messaging around how to do it well. And then there's the opportunity to also using tech and having that value that might obviate the need for Mrs. Jones to actually come into the office, and perhaps a treatment intensification can happen based on a validated value, but not necessarily requiring the time investment on the part of the patient or the clinical the clinical team to do the right thing for that patient. Having said all that, I want to sort of echo what I'm hearing George Bakris say as well. We have to have payment mechanisms and reimbursement mechanisms that support that kind of care. And during the pandemic, that existed somewhat, and there is the possibility that when the public health emergency elapses, that the way we were supporting telemedicine, telemonitoring of hypertension and other things may go the way of pre-COVID, and we're going to be needing to climb that reimbursement ladder all over again. So I'll stop there. There was a lot there, but your question asked a lot of stuff all packed in.
It sounds like.
Can I just go to low tech though first? Because the biggest issue out there is just the regular home BP cuffs that people are using. There's over 3,000 devices worldwide, 450 plus manufacturers, and less than 15% of them have actually are devices that have gone through independent validation testing. There's part of me that just wishes whatever was out there was actually validated. So, I mean, I think the point that Dr. Sanchez, I think it was him who made that, you know, bringing in those devices to us, also just the check-in type of thing, I think is so important so that we can go over that. So I also tell them that their blood pressure cuff comes in once a year at least, so that we can make sure that it still works. And also that way I get to know what device they're using at home.
I wanted to follow up on the low tech as well, because something that we haven't mentioned is the role of diet, the role of exercise. We know combined, if they're done right, they could have maybe 10, 15 points, particularly in systolic blood pressure. And that's why I think low-tech patient education is very important. And, WebMD, we have Cranes, which does a lot of the after visit summaries. It has to be the right education and the right level and the right language. And I think to George's point, part of the challenge is, we have these great diabetes educators that we created as a system. We have, cardiac rehab that talks about it, but we don't have it, paid for if you have high blood pressure, to be able to talk to someone about nutrition and what the Mediterranean diet is, or another diet or exercise. But then even when we talk to patients about blood pressure, I always find it fascinating that more patients will get a glucometer and prick their finger every day, which to me seems much more intense than they will take 5 minutes, 10 minutes to do an accurate blood pressure, and then come back with the numbers, either to write it down or what have you. And there's still a lack of understanding on patients, and that's partly the physician side. And George, you and I talked about this once before. What is a normal blood pressure? And that's what patients will say to me. What? Okay. What is normal? Is 130 normal? Is 140 normal? And then you totally forget about the diastolic. So I don't know if George wants to respond to that. So that's the issue.
Yeah.
And then it matters whether your blood pressure, no doctor, because when I tell patients, they're like, I never heard this. I'm like, your blood pressure in the evening is an important indicator. You need to take it at different times of the day. Then patients take it every day at the same time. And I'm like, I want to know what it is in the evening. If it's high in the evening, I'm particularly concerned. I want to know what it is in the morning.
I agree 1,000% with that. I do want to make a point, and just to reinforce what you said, this is real life. I had 2 patients referred to me from cardiologists that were, quote, advertised as resistant. They were on 3 drugs, and there was absolutely nothing else wrong with them. They were totally clean. The labs were great. And I asked them, how much salt are you eating? And they were offended. I said, I don't eat any salt at all. I said, well, how often do you eat out? Oh, 4 or 5 nights a week. Oh, but I don't eat it. I don't put any salt on it. I said, that's fine. I said, do you mind if we check it? So I did a 24-hour urine. It was 10 grams. And I said, here are the results. She goes, well, what does that mean? I said, well, you're supposed to be at 2. Oh, we got her and worked with her for 6 weeks. She was on 3 meds, 3 appropriate meds, including a diuretic. She came off everything with a pressure of 128. And then she came in 4 months later and she says, she was crying. She says, I can't go on like this. I need some salt. I never realized it. So we set up a plan on the times that she was going to use it. I gave her a potassium sparing low dose diuretic just for the day, pre and post. Her pressures have never gone above 140. I've been seeing her now for over 10 years.
You just told us you never use diuretics.
No. I never use them as first line, doctor. So I think the point is that if you look at the bulk of the data, and this is a debate I've had 3 times now about the 120 that the kidney guys put out. And the truth is this, if you measure blood pressure correctly, then it should be probably less than 120. But given the way we measure it and the sentiment, less than 130 is good enough because you get down in the 120s if you're there. So it's a compromise. You go to Europe, it's 140. Unless you have diabetes or kidney disease, then it's 130. So I think the world can agree less than 130 without a lot of arguments.
And it sounds like the guidelines are really coming together for that 130. It also sounds like, Dr. Sanchez, that on our next webinar, we should have somebody representing the payer side come in, because some of this feedback might be falling on deaf ears without having the payers in the room also. There is one other thought, which is, Dr. Whyte, you were talking about, and Dr. Gulati as well, when we are having patients measure, you want to know what's the nighttime measurement. What is your blood pressure in the evening? And what I've heard from some patients is, well, I don't want to measure it in the evening because I'm feeling stressed then, and I know it's going to be high, or I don't want to check it in the morning because I've had coffee and I know it will be high, and I don't want to see that because I know what it is. Now, if these patients are always stressed or consistently drinking coffee, or, I find it interesting, and I'd love to hear, Dr. Whyte, your comments on it. if patients are naturally in a state of stress or coffee or eating salt and so on, why are we measuring it after 5 minutes when they are relaxed and then we want to get their blood pressure in that way? And they're in that perfect condition as opposed to their natural state. Why shouldn't it be normal to take blood pressure right after they just ran into the office in a hurry?
One is, I always tell patients, you don't need to please the doctor. There's a bunch of patients that want to be good test takers, right? So they don't want to have a bad measurement, right? So they have a lot of caveats, like you just said. I want to take it in the evening, I want to take it in the morning, then they don't take it at all. And what I talk about is, what's the context? I saw a patient this morning, young guy, 24, his pressure was like 150 over 82, and his heart rate was like 110. I was like, are you nervous? And he's like, no, I was late. I ran over, like literally ran 5 blocks over here. And I waited till the end of the visit to retake it, and everything was normal after saying, you ever been for blood pressure? But here's the tricky part. It was in the chart, and then that's going to cause challenges too. So part of it is giving patients the context of when their blood pressure is taken. But as we've talked about before, I'm a big proponent of tech. Tech is only going to get better in terms of the product. We don't have a smart watch that accurately measures blood pressure. There's some out there, but they're not medically grade. They're not, really ready for prime time. So I think they're going to get better. We can have more measurements over time. And that's the data that patients need, that clinicians need, to really make decisions about how much therapy they need. I mean, Dr. Gulati, do you agree with that as well?
I do. And I also think that, when your question about the state of when you're checking the blood pressure for creating a false environment, that's why I think I rely so much on home blood pressure assessments, because you are letting them be in what is their normal environment. And even though we tell them to do it at a quiet time, still real life's going on in the background. Kids are screaming, people are yelling, whatever is in your normal life. Maybe I shouldn't say too much. Dogs are barking usually. So whatever is your normal life, that actually will get through the home blood pressure reads. Also ambulatory, we haven't talked much about ambulatory blood pressure cuffs, but if you really don't know, I use that to really reflect what's going on in their life. If they're always under stress, we should have a reflection in their blood pressure of those reads and be able to more accurately make a decision for that individual.
A lot of our colleagues don't know how to do it.
Right.
It's not often covered as well. There can be a lot more hoops. I've tried to get it done on patients at times. It can take a lot of effort, but I agree with you. It can be very useful data. It's vastly underutilized.
Yeah, definitely.
Hey,
A word on context. I think, in terms of why we do resting blood pressures, at least with regard to office and self-monitored, that's where we have the prognostic data. We also have prognostic data around ambulatory, but it's less available in general clinical practice. There's also a fair amount of data in the literature about stressing patients, and that's been done in small studies, but these stress blood pressures are often responses to exercise, are pretty well documented as related to outcomes. It's just that it's standardized in these research protocols. We don't have a way of standardizing to assess really for an individual patient. So I think that's part of it. There's been mention of technology, I think, to the point where wearable devices that do basically beat to beat blood pressure, highly frequently blood pressure, that we can transmit and get organized, I think we'll have much better prognostic information. So I want to agree with my colleagues that say tech is moving there. And there are a couple of wearable devices doing beat to beat blood pressures that look like they're getting pretty accurate. So I think in a period of time, in our lifetime, in a reasonable period of time, I think these devices will be available as well. Just a brief comment on a consensus around a target 130. And I know that's where the ACC/AHA guideline. Let me just say, if we consistently control blood pressure to less than 130, the mean systolic is likely to be less than 120. We don't have data that for groups of patients, treating them to a mean systolic blood pressure of less than 120 is effective. It may well be, I'm not saying that it isn't, but what I'm saying at this point, We don't have data on a group of patients treated to a mean systolic blood pressure less than 120 that that's a beneficial thing to do. So we could do it based on expert opinion, but it would not be based on the science currently available to us. I just raised that as a potential caveat to, but here's the other concern. Once we set the 130, then the payers in these incentive programs incentivize the health systems and the clinicians for high control rates. If you achieve 80% control to less than 130, I think it's highly likely that your panel of patients will have a mean systolic blood pressure less than 120, which is below the evidence on which the guideline is based. That it's a bit of a concern. Do I think many clinicians or health systems will get to 80% control rates? I don't. But if they get enough incentives, they're sure going to die trying. And those incentives are, for at-risk contracts, those incentives are getting pretty strong. Just one example, in the MSSP, the Medicare MSSP program, the highest incentive rate for blood pressure control is the 90th percentile, which CMS has defined as a blood pressure control of 90% or higher for your patient panel. The data also suggests that once you get to 90% control rates or higher to less than 140 over 90, it's probably going to require a mean systolic less than 120. And I don't mean to bore people with the details and the numbers. Blood pressure is variable. In order to achieve these consistent control rates, you need to get more, close to 2 standard deviations below the mean. If the standard deviation is 10 or 12 millimeters, 2 standard deviations is going to get you to some of those low readings. That's
Dr. Egan, one follow-up question on diagnosis still, and then we'll go a little bit more into management. There's a question from the audience. As we're talking about this future state of the equivalent of continuous glucose monitoring to continuous blood pressure monitoring, right, which I think is what you're getting at. Yeah. Is there, do you think, the direction of the guidelines to go into a percent in range for blood pressure, like we have percent time in range for diabetes? Like if you're 70% in range, then your mean is going to be less than 130 or less than 120. Do you think that the guidelines will go there as the technology goes there?
I think the guidelines will go there, and I think should go there. George remembers, we've been in this field for a long time. We used to talk about blood pressure load. And if you did a 24-hour blood pressure, what percentage of those readings were high? And we used to say we really wanted the blood pressure load under 20%, which is why I'm sort of saying 80% of the readings plus in control. We used to talk about, now they're talking about time in control, which is a similar concept. Yeah, as technology gets better, we can be much more precise in doing that. Having said that, what our medications generally do is lower the mean blood pressure. They don't really reduce relative variability all that much. So the variability continues proportionate to the blood pressure level, but our medications are really lousy at reducing blood pressure variability.
So let me jump right in there and agree with Brent 10,000%. He's spot on the money. And let me also tell you that I chaired the ADA blood pressure guidelines in 2017, and I brought up the concept of forget about a number. Let's talk about range. And I was vetoed, almost booed out of the room. There's no randomized trials that looked at this. There's no this, there's no that. So yes, I think to the people in the blood pressure arena, they're for it. Outside of it, forget about it. And the evidence-based mafia, alive and well, till you do 6 trials and show that they're all good, forget it. So there's some stupidity going on too. So I think that one has to be very careful about this. The other thing is, we haven't talked about this at all, but you want to talk about blood pressure variability. True story. I was referred a bunch of 30-year-olds that worked at the Board of Trade in Chicago. Why? Because they all developed bloody noses, and the nurse there checked their pressures. They were 180, 200. These were young guys, athletic, etc. No medical problems. I did a 24-hour ABPM. Their blood pressures were 110 in the morning. They got to work. As soon as the bell rang to start trading, within an hour, their pressure was 150. Within 2 hours, it was up to 180. It stayed up in that range until they left work. Within an hour, it was back to 110. Now, that happens to a lot of people with a lot of left brain jobs. And we were totally missing that. You'll miss it at home. You're going to miss it in the office. It's there, and that wears on the arteries over years, and then all of a sudden, problems happen. I don't want to get into mass hypertension. That's a whole nother kettle of fish. But I just want the audience to hear that that does exist. It's alive and well. And the mortality in that group, at least the data that exists, is higher than people with white coat hypertension. So FYI.
And that kind of brings us into management, thinking about lifestyle, thinking about diet, exercise, life. Dr. Sanchez, can you comment more on what our clinicians, our patients, our audience can keep in mind as we think about treatment beyond just medications?
Yeah, happy to do so. And I will remind everybody that Dr. Egan kind of started there and said that among the things that gets in the way are the modifiable risk factors that include lifestyle issues, around which while they absolutely could make treatment more difficult, they also provide opportunity for not only helping to manage and reduce blood pressure, but also all the collateral benefit of things like helping folks with weight reduction, helping folks adopt a DASH eating plan. And I say it that way, not necessarily wholesale on day one, but beginning to make the changes that add more fruits and vegetables to a diet, lower sodium. I think Dr. Bakris's main message was maybe eating out 4 to 5 days a week is counter to trying to reduce your sodium. There is value in physical activity. And I think everyone, I'm hoping all the folks who are listening know that some movement is better than no movement, and more movement is better than some movement. And while some movement may not reduce blood pressure, some movement, there's good evidence, helps increase longevity and reduce mortality. And then lastly, let's not forget that alcohol can play a role in some people with regards to blood pressure control. And the last thing I'll say is that if our patients are smokers, talking to them about smoking, while it may not directly affect blood pressure control, it's going to absolutely affect their long-term trajectory in a positive way towards a longer, healthier, cardiovascularly healthy life.
I would want to quickly endorse what Dr. Sanchez, Eduardo has said. You know, if you look at the data, it looks like each additional fruit and vegetable beyond ketchup and French fries lowers blood pressure about 2 millimeters of mercury and reduces cardiovascular mortality about 5%. So it really is important. The fact that we have such poor lifestyle patterns not only raises these risk factors, it accelerates aging. I mean, this is really a disease of accelerated aging for a lot of people. And we accelerate aging with our poor lifestyles, our poor diets, our lack of physical activity, and so forth. And then often the excess weight that follows it. So if we can get healthy lifestyles, it's very beneficial.
Don't you think you can turn that into a very good ad? I mean, I think that's age faster if you continue in this way. Almost parallels get blind if you don't control your diabetes. It's almost there.
And let me just say, you know, I'm so glad you mentioned a thing. One thing we're not talking too much about with regards to blood pressure control and the benefit of it, blood pressure control will help delay and or prevent cognitive decline. The evidence is pretty compelling. And it may be that we need to figure out for which audience is the compelling message the one that we ought to be delivering, and have sort of a multiplicity of messages to get people interested and activated to think about lifestyle change on the one hand and blood pressure control if that needs to be addressed on the other.
I see an advertisement starting to form over here, which really can move the needle, right, as it did for diabetes. Moving into not just management of lifestyle, but into the blood pressure meds. One question that comes up, Dr. Gulati, if you can take this one. Should patients be taking blood pressure meds at night, or does it not make a difference?
Patients should be taking blood pressure medications. So They should just be taking them. And so now that we have some studies out there showing that it didn't really make a difference when patients took their blood pressure medications, when are you going to remember to take them? If it is going to be nighttime, then nighttime is when you should take them. If you're going to remember them in the morning, then that's when you should take them. And we just need, I think that study was so important to many of us so that we can just make our patients' lives easier. I think that, again, we have 45% of the US population who have hypertension who are uncontrolled. We're not doing a lot of things right here. So we also have to work with our patients and make their lives easier, meet them halfway. And if that's when they want to take their medication, so be it.
Let me build on that. There's an international consensus report that I was part of that we just published in the last 2 months, specifically on this question, and couldn't agree with Martha more. There's absolutely no difference. And I think it's important. The other thing that's important is a lot of younger physicians haven't had the pharmacology, apparently those of us that are older have had. So there are drugs that really don't last all day, and they're giving them once a day. There are drugs that really only last 6 to 8 hours, and they're being given once, maybe twice a day. So you need to understand how to dose the drugs, apparently, because if you don't, even though the patient may be taking them, you will not get the right results. And I see this day in, day out in referrals. That's the only reason I'm mentioning it.
And then to kind of,
I'm sorry, I just want to make a comment. We talked briefly about single pill combinations. Patients typically require more than one medication. They count pills. We do know from the literature that the more pills we prescribe, the less likely they are to be taken, that the medications, when we put them in single pills, adherence goes up, blood pressure control rises, cardiovascular morbidity and mortality decline. Now, it's not all randomized controlled trials, but these are good, well done, many of them observational studies with good databases. So single pill combinations can improve adherence, improve blood pressure control, and improve patient outcomes. When we look at the national data, about 7% of blood pressure medications are prescribed in single pill combinations. So we have a wonderful tool that's not being used, and there are obvious barriers there that we need to begin to understand and figure out, because our patients prefer to take fewer pills, and they're more reliable if we give them fewer pills to take.
And let me quickly, true case, referral from the Cleveland Clinic, an attorney who walks in and tells me, I know that I have hypertension. They say you're good. I'm telling you right now, I'm not taking more than 2 pills. I know it's crazy, but I'm not taking more than 2 pills. Why? Because I'm sick if I take more than 2 pills. So I said, can I play around? Yes. So when we finished, she was on 2 pills. And I said, counselor, full disclosure, you're on 4 medicines. I don't care. I'm on 2 pills. Just to make Brent's point.
well, this has been a wonderful discussion, and I thank all of you for joining us, especially thanking our panelists for the really expertise that you can provide across the range. And there really does seem to be a consensus. And with that consensus and some of the problems that do need to be addressed, I think there really is a path forward, right? We can teach our patients about the risks that can happen if blood pressure is not controlled, including dementia, including aging, talk about strategies that can really help in as far as management of blood pressure, as far as diagnosis of elevated blood pressure, and really come together as one, as we really have now what is unspoken in hypertension management be spoken. So thanks for everybody for joining. For the topic of protocolization, if anyone would like to access the AHA-ACC guidelines, they are of course accessible. And then AvoMD has digitized them into a protocol, which can work within or outside of the electronic health record. And so we provide that freely for anyone that would like to use it. And it's been reviewed by the American Heart Association as well. And we really thank all of the audience members for joining us here today. And I hope everybody has a nice day. Take care.
Thanks.
Right.